I'll be speaking on basic surgical skills. I think much has been covered by the earlier speakers wonderfully well. So I will try and avoid those topics and touch on those aspects which I feel also needs to be understood and is also important. So if you look at the learning cycle, this is what happens. The first phase, look at a postgraduate who just joins a course. Right? The first phase is that of unconscious incompetence. That means he really doesn't know what he's doing and he doesn't know how to do it as well. The next phase is when he acquires some amount of knowledge. So that's the phase of conscious competence. Now he knows what is right, how it should be done, but somehow he lacks the skill that is required to do it. Now the third stage is even better. That's a conscious competence. That means your mind or your brain is telling you this is how you need to do it. It keeps reminding you, and that is how you are able to complete your task. And finally, that is the pinnacle that you are going to achieve, unconscious competence. That is a rhythm, a flow that you see. Things just happen. You don't have to think about it. It's just like a reflex. And that is the final stage in your surgical or any career for that matter. We all know this great man, right? You have a century of centuries in his name. But what we really do not know is how many hours he has spent in the net actually practicing. I would say that it is really criminal for a person, for a resident or anybody to go and operate directly on a patient in the present day scenario. You have fantastic wet lab facilities available all around you. Earlier speakers have spoken about developing your hand-eye coordination. Let me tell you one thing, suturing is one thing which is the most important. Do not neglect suturing. Invest in microsurgical instruments, buy a needle holder, buy a forceps and suture tying forceps and one tooth forceps. Practice suturing. Remember the rule of 10. 10-0 sutures in 10 minutes in your wet lab. That is what you need to do. Now just covering, I don't know how to start these videos though. I think much of the rest of it is already covered by the earlier speakers. So I'm just going to emphasize on your hand position during a cataract surgery. So this is a routine cataract surgery. This is actually an unedited video. So on your left side of the screen, you will see the hand position. Now you see that the hands are rested properly on the face of the patient or the rest that you have where the patient's head is resting. Please do not hold the conjunctiva with the forceps. Do not tear the conjunctiva. Your movements should be smooth and fluid. So look at the way the instruments are held. All your movements are with your fingers, with your thumb and with your index finger. Do not press on the posterior lip. Do not lose equus. Your incision is what is going to define you. It should barely nick the limbal vessels. Do not make an avascular incision. Those are very hard to heal. Learn to hold the cannulas and the syringes. Always make it a habit to hold the hub of your cannula. Sometimes if the cannula is loosely placed, it can just jut out of your hand and it will cause irreparable damage. Trust me, I have had this experience. So always use two hands to hold the cannula. This is another important step. The nursing assistant will give you a viscoelastic. You need to always make it a habit to tighten it. So tighten the cannula at the tip of the syringe that you have. While doing capsular access, doesn't matter what you use, you can just drop some viscoelastic on the cornea. That saves you the trouble of constantly wetting the cornea. You're using a cystitome here, two-handed technique. Your right hand or the dominant hand is the primary hand here, and your other hand is just stabilizing it. Do not press on the posterior lip. Do not lose the viscoelastic that is there in the anterior chamber. Now you are using a microforceps here to achieve the rhexis. Doesn't matter what technique you use. Ultimately, you should be learning all the techniques and you should be the judge, which is the one that suits you the best. Pivot in the incisions. That is the most important thing when you are handling the microsurgical instruments. Do not press on the posterior lip. Pivot in the incisions. You don't have to enter and re-enter the anterior chamber again and again. Again, while you are doing hydrodissection, make sure you have held the hub of the cannula there. Look for the wave of fluid. Decompress. Remember, there's only so much of space between the nucleus and the posterior capsule. Keep injecting, it will blow out. Have one more wave from the other side. And then try and rotate. Remember, if it doesn't spin, you're not going to win. So spin the nucleus. Hold the phaco probe or any instrument that you have like a pen. So hold it gently like a pen. Look at the second instrument, the fingers that you are using for holding the second instruments. All your movement should be within your thumb and the fingers, index finger primarily. So it doesn't matter what technique you use, the movement of the hand and fingers are of the prime importance. Look to your left side, the movement of the phaco handpiece outside. You see it's moving more than 30 degrees or so, but the movement inside there is hardly a millimeter or so. The entire surgical process should take place like a fine orchestra. Each particular step defines how your next step is going to be. Your fingers are nicely supported on the face of the patient, and everything is going on very smoothly as you have planned it. This particular patient in question has Fuchs dystrophy, so need to be extra careful here. So try not to work near the endothelium. While you are withdrawing, withdraw your second instrument first, not the phaco probe. Train your left hand, the non-dominant hand. See, here you are injecting viscoelastic using only with one hand. With your left hand you are injecting viscoelastic. See the way it is supported. Always look for a risk-free surgery. So do not do anything that you feel will give rise to some complication. If you see shallowing of anterior chamber, inject viscoelastic, form the anterior chamber, and then clear off all the cortex or whatever else that you are doing. Aim to achieve this flow. So once you have this surgical flow, so-called surgical flow or the symphony in question that you have, things will follow. And that is the confidence that you should be developing as a surgeon. No matter what is the complication that you create, you should be confident enough to handle it. Always remember, mistakes are bound to happen, but you need to convert those mistakes into lesson. How do you do that? By learning from it. Mistake is never a mistake, but it becomes a lesson when you learn from it. Here you see that I am not able to approach that small chunk of cortex. So inject a bit of viscoelastic there, form the chamber. More importantly, know your limitations. So these are some things which I can do, these are some things which I cannot do. Remember that you are not competing with anybody else. You are competing only with yourself. You need to be your own toughest critic. You need to go back, look at your own surgical videos, spend time with it, see what you have done wrong, and try and rectify it next time around. Have your mentors or your seniors look at your videos and let them advise you regarding what needs to be done. I think many times in an institution where you have so many people around you, you have so many nursing assistants, the staff, they do most of the work. But remember, once you are out of the institution, the only person who is answerable to you is you. Otherwise, you don't have anybody else around you. You are responsible for your patient, you are responsible for your machines, your trolley. You need to know in and out of your machines, your trolley, how to set up the equipments. Say how to load your lens. Many times in many surgical centers, it's the nursing assistant who loads the lenses. So learn how to load your lenses. Now you have so many different types of lenses, so many different ways it can be loaded. So learn all of it. Remember to learn all techniques. When you are doing a phaco, divide and conquer is important, yes. Stop and chop is important. Direct chop is important. Learn all the techniques. Each of them will have its place. See what suits you the best. There is no right or wrong here. Somebody is doing a good divide and conquer, somebody is doing a phaco chop, there's nothing wrong in doing a divide and conquer. So while you are injecting the lens here, use your second instrument to fix the eye. So do not push the eye downwards. See how it is fixed? It's fixed nicely. It's important to have the eye in primary position. Many times I have observed when residents, they are operating, the eye is in some weird position and you are not able to actually get a very good red glow or the depth perception that you need. So keep the eye in primary position. Remember that the lens, objective lens of the microscope should be parallel to the plane of the iris that you have. That way you will get the best of the red glow and best of the depth perception. So these are some of the common mistakes which I have encountered, which I myself probably have made, not knowing your patient. So most of the times the residents, they just come to the operating table, somebody has painted, other co-PG has blocked, and you are just sitting and operating. You have no idea about the comorbidities of the patient, you do not know the other eye status, you just want to operate. Not knowing how to set up your equipments, nothing can be worse than that. Somebody, I think, has earlier have given a lot of insight on how to drape and position the patient. Remember, eyelashes need to be sequestrated. You have all kinds of organisms on the eyelashes, and they are the primary cause of endophthalmitis. Remember to place your incisions well. Your incision is what is going to define the rest of your surgery. If you have a very shallow incision, it is going to leak. If it leaks, you will have shallowing of the anterior chamber while you are phacoing and you will have a rent. Keep the eye in a primary position, always, and learn from every single case. So this is something which I have encountered in one of the articles in NET. So the x-axis actually shows the years, whereas y-axis is the skill level, and the blue line that you see is that of a surgeon who drops out, and red is that of a competent surgeon, and green is that of an expert surgeon. So, video run. So we'll talk about it a little bit more while in the background you're going to see a video of a traumatic cataract with a fibrosed anterior capsule which is being operated upon. You look at the graph here, all the three graphs start at the same level and stay almost the same during the entire 3 years of residency, right? What happens to the blue line? Somehow he is not able to overcome the frustration barrier and just drops out. Look at the red line, that is of a competent surgeon. He is going to do what is being taught to him in the residency and he will continue to do that his entire life. Not that he is incompetent, but that is how he is. He is somehow caught in that zone of mediocrity. He is not able to penetrate that passion barrier. Now the expert surgeon breaks the passion barrier, enjoys doing more and more the tougher cases. In fact, he tells his colleagues, if you have any tough cases which you can't handle, please send it to me, I will try to manage it. And now he becomes the true master of surgery. So true mastery doesn't mean that you stop learning. You still learn from each and every case. Remember that when we were postgraduates, we didn't have anti-VEGFs, we didn't have OCTs, we had LASIK and refractive surgeries had just come in, ICLs were not there. We all had to learn it later on. So learning is a process that never stops. So today, what is the best possible procedure as of now today is not going to remain like that in the next 10 years' time. It's going to be something else. So you have to keep evolving with time. So many times I have heard the postgraduate students tell me that they are probably not there in the right residency training program, they do not get enough cases. I always tell them it really doesn't matter how many cases you do, whether it's 50, 100, 200, doesn't really matter. What matters is how much you learn from each and every case. So that is what is important for a resident. So do not look at how many cases you are doing, look at what you've learned from every case. Remember, it is not the horse that wins the race, it is the horse that wins the race, not the track. A good cook will probably, in any kitchen that you give him, will come up with a delicious or a very, very good dish. So it depends on your inclination, your learning ability and the motivation that you have. That defines you and that defines you and that should be defining you for your learning. So these are, I feel that many times there are certain scenarios where you are so eager to operate, but you really, there are certain scenarios. A better surgeon probably knows when not to operate. One of them being unrealistic expectations. When the patient, 80-year-old man tells you, I want to have the vision of a 25-year-old person, not going to be possible, isn't it? When the risk is more than the benefit, especially when you are looking at resurgeries. When there is uncontrolled comorbidities, remember that you are not just handling the eye, the patient is looking up at you as a whole. You have to look to the patient as a whole. If he has comorbidities like uncontrolled diabetes, cardiac issues, COPDs, not being able to lie down, you need to postpone your surgery until such time that he gets better. And most important is your ego, not knowing when to refer. So if there is something that you are not able to handle, there is nothing wrong in calling your colleague and helping him, asking his help. Please do not get caught in the spider web of complications. Learn from them.